I think we now have 4 FDA-approved therapies for NMOSD, but before there were the 4 therapies, there were existing drugs that have been used for years. Those include rituximab, and so the burning question in the field is how do the new therapies compare to the old ones, right, that had been used that were not part of the trials. The trials were mostly placebo-controlled. So the point of the study was to take a look, a real longer-term look at therapies, all of the therapies together, and see if we could map out any differences in relapse rates and, more importantly, also in rates of complications such as infections and other things. So we were able to look at 178 patients with NMOSD and follow them up on average for about 8 years together to get a look at the different therapies and how they have affected them. The main results that we found were that rituximab continues to be the dominant therapy that's used. In our cohort, there were 100+ patients who had different periods of treatment with rituximab. So that remains the dominant therapy used. Surprisingly, there was about a 30% failure rate of rituximab use, meaning that in patients who were on rituximab, they had an event that was thought to be an NMO relapse on rituximab, which is high compared to the newer therapies. In our study, at least, even though they had shorter observation times because they were more newly approved, none of them actually had a relapse, NMO relapse on any of them. So that to me was surprising in the sense that can we understand who are these 30% who get these relapses, and if so, what makes them different from their 70% who don't have relapses, and can we better sub-select out which patients benefit from which therapy? The other surprising thing was that we looked at infectious hospitalizations in there, and for the rituximab cohort in particular, if you look across the time of follow-up for the patient, about 29% or so of the patients had an infection-related hospitalization, which is an equally important thing. We are very often as a field focused on relapses, but perhaps not enough on infectious hospitalizations or other serious complications of therapy. And just taking a step back, traditionally, medicines such as azathioprine and mycophenolate mofetil had been used in NMOSD. And the other part we saw, and that's something that's reflective of prior experience as well, is that there's a really high rate of failure in the traditional oral therapies, just driving home the point that they're probably not appropriate in this day and age to be used as a first-line therapy as well.
Do you think part of why the rituximab cohort was so large is just kind of that lack of treatments, or is it potentially driven a little bit by access challenges? I don't know as much.
Right, it's probably a little bit of both, right? So probably the number one reason is that that these are newer therapies, right? The other reason is that if you're on rituximab and you're doing okay, the question is often, why should I switch, right? So, and then thirdly, there is a barrier to access in the sense that you have to go through a prior authorization process again. These are costly medicines. The copay changes may occur. So all of those things play a role into barriers to having people switch.